So let's take a deeper dive into leadership, starting with leadership attributes or competencies. Just as everyone has their own way of defining leadership, essentially meaning the same in different ways, there are also a number of attributes or competencies that can be considered as we start to develop or refine our own leadership abilities. A Harvard Business Review study provides an interesting ranking of attributes by leaders in global organizations all over the world. The top 10 attributes these leaders identified include high ethical and moral standards, provides goals and objectives with loose guidelines direction, clearly communicates expectations, flexibility to change opinions, committed to my ongoing training, communicates often and openly, open to new ideas and approaches, creates a feeling of succeeding and failing together, helps me grow into a next generation leader, and provides safety for trial and error. The results certainly appear to reflect the current global issues being faced. Perhaps more than just the list of attributes, the placement of high ethical and moral standards at the top of the list may be the most important aspect on the list. Of course, ethics and moral standards could also be considered loaded terms. We'll actually spend a moment considering these terms in the next slide, but for now we can cite Merriam-Webster's definition of ethics as the discipline dealing with what is good and bad and with moral duty and obligation. Another interesting aspect of this list is the looseness or lack of rigidity conveyed by the attributes. Consider loose guidelines direction, expectations, flexibility to change opinions, open to new ideas and approaches, failing together, and safety for trial and error. The leaders describing these leadership attributes clearly are engaging those they are leading to take part in the leading process, and indeed, the ninth in the list, helps me grow into a next generation leader, says just that. You may want to pause a moment and reflect on this list. What traits do you have or aspire to cultivate further? Do the persons with leader titles you work with have these attributes? Finally, I think this list is laudable for its universality. The participants in the survey are all leaders in global organizations. They represent anything from something like the World Health Organization as a nonprofit organization focusing on advancing health and leading partners in global health response, to for-profits offering goods or services or both, such as Accenture, Apple, ExxonMobil, IBM, JP Morgan Chase, and Toyota, as among the largest global companies in the world. Leadership attributes are not unique to the domain in which they are practiced, although as we will see further along in the lecture, there are some domains that cultivate leadership traits as part of entry-level training or ongoing practice building better than others. As ethics is the highest on that leader list of attributes that we just looked at, let's pause for a moment to consider the issue of what ethics means. In healthcare, we look to the National Institutes of Health Belmont Report as classic work on ethical guidelines, although as we observed in the last slide, it can apply across all domains. The Belmont Report describes ethics as a process of reasoned discourse or discussion among decision makers in order to identify what is the right or good thing to do, often when faced with potentially conflicting choices, and often where there is no legal guidance. As such, ethical decision-making requires everyone to consider the perspectives of others, even when they have different values. Because the Belmont Report focuses on health, it also defines bioethics as involving problems or issues regarding clinical care that are never strictly theoretical but must always result in a decision. The principles espoused in ethics are respect for persons and their autonomy and privacy. Beneficence, meaning promoting good and doing no harm. which is also part of the Hippocratic Oath. Justice, meaning treating others fairly in distribution of benefits and allocation of risks or costs. The Belmont Report was released in 1978, but it sure reads like a reference focused on value-based care for today. Now, sometimes words like respect for persons, beneficence, and justice are difficult to remember or pronounce. An ethicist friend of mine likes to suggest replacing these words with the good, the bad, and the ugly. If one does not do good, something bad will happen, and when something bad happens, it can get ugly. This pause to focus on ethics is important because any time risk is introduced into a process, it can generate an ethical dilemma. We've mentioned the possibility of doing more joint replacements than medically necessary if we are able to streamline our processes to consistently save money. Generating more revenue or income through more of such procedures would seem like a good thing. After all, hospitals and physicians need to stay afloat, if for no other reason than to cover the downside risk and other procedures we must perform to maintain a healthy population. Alternatively, however, there is a risk in performing medically unnecessary procedures, not only in being considered unethical by many and potentially harmful long-term for patients, because of course any surgical procedure introduces risk, but because law and/or contract considers such to be fraudulent and subject to civil or criminal penalty. Included on this slide, then, is a list of steps to take in ethical decision making. These steps include stop. Is this an ethical dilemma? Consider, what are the relevant facts? Who are the key people involved? Identify, what courses of action could be taken? What conflicts arise from each course? Which course of action seems best? Evaluate. Compare proposed course of action against ethical principles. Is there consensus to act? Need. Is there consensus to act? If not, consider additional facts, other courses of action, and evaluate. This is not negotiation, but recognition of a best course of action to take. Conduct action, and evaluate results for future consideration. This list of ethical decision making is dubbed science, and it can be applied when there is any choice to be made with respect to risk in value-based care or other avenues. Among those wanting to assure success with accountable care organizations and other value-based payment mechanisms in an ethical manner is the National Business Group on Health. This is an organization comprised primarily of human resource and benefits managers from major companies that is focused on optimization of business performance through health improvement and healthcare management initiatives that can save time and money. The U.S. Chamber of Commerce estimates that U.S. employers are spending, on average, 12% of their revenue directly on providing health insurance for their employees. This does not include productivity loss for workers who are ill or injured, or other indirect costs of benefits management or taxes which fund entitlement programs such as Medicare and Medicaid. The National Business Group on Health released an ACO Journey Map, which is essentially a maturity model for employers to use in evaluating any ACO with which they may consider contracting for health benefits for their workers. This model suggests that it takes about 3 years to launch an ACO or other form of value-based payment, 2 to 5 years after launch to develop it fully, and then 4 to 8 years after development to achieve high performance. Their first consideration in this ACO Journey Map was that they referred to as clinical governance, or the leadership of the ACO. Although not measuring the competency of individuals in leadership positions within an ACO, the maturity model considers provider input and approval of clinical and operational goals, oversight of quality and patient experience, and accountability for achieving sustained high performance in an ACO. These leadership activities are all clinically oriented and require not only clinical input, but clinical leadership that engages all colleagues in embracing the requirements for ACO success. This is especially true when an ACO is established by a hospital or health plan rather than a physician group practice. Physicians often find that such arrangements are done much like any other contractual arrangement under fee-for-service, and often find they are not a part of the initial planning or an integral part of ongoing operations. The additional elements of maturity in the ACO journey map include development of primary care and specialty networks, such as narrow networks of specialists who are known to embrace value-based care to ensure quality and cost efficiency. Care models such as the patient-centered medical home, risk stratification, use of clinical guidelines, care coordination, a focus on medication management, including polypharmacy, medication reconciliation, and evidence-based use. Consumer experience such as access, outreach, satisfaction, and portal communications capabilities. Technology and analytics capabilities. And finally, the ability to do financial modeling of risk and physician incentives. These are all areas we are discussing in this MOOC.